Medicine is an art and not a science, and it was the art that drew me in to become a doctor. Medicine is based on science. You need anatomy, physiology, and biochemistry to serve as a foundation in order to practice the art. But the art utilizes these sciences in order to heal sick patients. In order to practice the art, you need years of experience taking care of sick patients. You need to have a keen intellect and the ability to absorb knowledge quickly because the knowledge in medicine doubles every 5 years. And finally, you need to be able to truly empathize with your fellow man. Dr. William Cobb practiced the art of medicine until he was 77 years old. Dr. Cobb was my pediatrician in Huntington, West Virginia, growing up. And he and I got to know each other well because I was sick as a child. Dr. Cobb was paralyzed on one side of his body. At the age of 12, he'd had an ear infection which led to a bloodstream infection which led to paralysis. But this didn't stop him from realizing his dream of becoming a doctor. When I was too sick to leave my bedroom on the second floor of our house, Dr. Cobb would drive over to our house, tuck his black doctor's bag under his arm on his paralyzed side, and then pull himself up step by step, pulling on the banister in order to come to the bedroom to see me and treat me. His daughter Sandra wrote me that he was committed to his practice, kind, gentle, and brilliant, and always willing to help others. To me, I think he often willed me to get well. He said that the saddest day of his life was the day he left his practice for the last time and turned his practice over to a young pediatrician in town with the promise that she would take good care of his kids. Dr. Cobb inspired me to become a doctor. The greatest change in the history of medicine, of the art of medicine, occurred in the last 20 years, and you were never asked your opinion about it, and no one even bothered telling you about it. To quote a line from a Green Day song, there was a 21st century breakdown. Your doctor, whether it was your pediatrician, family doctor, or internist, no longer took care of you when you were sick and needed to be hospitalized, but instead turned your care, your life, over to a doctor who had never seen you before and knew absolutely nothing about you. And that doctor was called the hospitalist. Your own doctor refused to set foot in the hospital, treating it as though it was a condemned building about to be demolished. What were the forces that drove medicine from being an art into a business? There were several things that caused it. First of all, doctors no longer wanted to work the long hours of their predecessors, but instead wanted 9-to-5 jobs, and certainly didn't want to have to get up at 3 in the morning to go to the emergency room to see a sick patient. Second, taking care of sick patients can lead to bad outcomes, including death. And unfortunately, in our society, bad outcomes are often associated with malpractice lawsuits, something every doctor wants to avoid. But far and away, the most important point that caused medicine to go from being an art to being a business were the health insurance companies. By ratcheting down payments to doctors, in my field of gastroenterology, over 26 years, the decrease has been 60%, and increasing the pay of the health insurance executives and to their shareholders, the health insurance companies have made it unprofitable for your doctor to go to the hospital and take care of you as a sick, complex patient, and much more profitable to stay in the office and see as many patients as possible. When I first started practice 26 years ago, a busy internist might see 12 to 15 patients a day in the office. Now, with the use of physician extenders, who are nurse practitioners and physician's assistants, many of them see 40 to 50 patients a day in the office. Often you're seen only by the physician extender, with the doctor signing off on their work in order to get paid. Doctors look for cash in order to make more money since the insurance companies have cut down on their reimbursement. Many primary care doctors now do Botox injections in their office for cash for cosmetic purposes, after taking a weekend course and learning how to do so, even though such injections are much better left in the hands of trained dermatologists and trained plastic surgeons. There are also doctors who look for other ways to make money. Some doctors do tests in their office, such as echo stress tests for heart disease, in order to capture what's called the facility fee, or the fee that's paid for having something done in the office, when we all know that such tests are much more safely and better done in the office of a cardiologist. I once went to visit a new internist in Plano with the hope of getting her to send me patients. I walked into a refurbished office, and over the patient check-in area was a large sign in red letters that said, "Dr. So-and-so does Botox injections on Mondays and Wednesdays." I turned around and walked out of the office without meeting her. Now that we know who hospitalists are, doctors who take care of patients only in the hospital when they're sick, why is it bad for the patient and for the specialists to have hospitalists? First, let me say that I don't think that the problem is completely the hospitalist's fault, but I think it's the way the system is set up, and I think it's because of the lack of training. But the hospitalist doesn't know you, and often doesn't take the time or have the time to get to learn about you. Supplying the old records and gathering information, which should be the job of the admitting physician, is often not done by the hospitalist, but instead is left up to the specialist to do. The hospitalists don't truly take charge of the patient and make the patient their own. They often don't give the patient a business card, and many patients leave the hospital not knowing the name of their hospitalist or even what their function was. The hospitalists consult. I've often said there's no problem too small for a hospitalist to need a consultant for. I can get called many times a day by the same doctor for many different patients for problems that we learned to solve in medical school, and that they certainly don't need a specialist to be involved with. This takes time away from dealing with the truly sick, complex patients who it seems as though the hospitalist often can't recognize. There's a lack of a vetting process for the hospitalists. They just show up one day at the hospital and work, and we're supposed to work with them. Where did they come from? Why are they here now? What are their credentials? How hard are they willing to work? None of this is told to us. We're just expected to work with them, and then one day they leave, and there's a new hospitalist taking their place. Plus, they work shifts, meaning they can work 3 days at a time and then be off for a week with a different doctor taking their place each day. I don't know how this slide got in here. This was supposed to be on my talk on Melvilles, Moby Dick, but let me see if I can somehow relate it to this talk. There are good hospitalists, just like there are good doctors in every field. But the transiency of their profession, the workload that they face, and the shift work that they do keeps them from being able to truly captain the ship when it comes to taking care of the patient. How do we fix these problems? Two major problems: the hospitalist problem and what happens to you when you're in the hospital, and the problem with the health insurance companies. For the hospitalist problem, I've divided it into 3 parts: the hospital stay, the beginning or the admission, the middle of the hospital stay, and the end or the discharge. You need to tell your primary doctor that you want them involved in your hospital stay, or consider finding a doctor, and there are still a few, who will take care of you when you are sick and need to be hospitalized. You need to make sure that your primary care doctor knows it's their responsibility to get your old records into the hands of the hospitalist. Discussions regarding possibilities for your hospital course, outcomes, and even DNR, or do not resuscitate status, should be held with a doctor who's known you for 20 or 30 years, and not with a doctor who's known you for less than 20 minutes. I once had a 49-year-old woman who was admitted to the hospital to undergo dialysis for kidney failure. I went to see her as a social call, and her door was close to her room, and on the door was a sign which said in big letters, DNR, do not resuscitate. I said to her when I walked in the door, why don't you want to be resuscitated? Why don't you want to live? You're 49 years old. She said that the hospitalist had spent 10 minutes talking to her and had convinced her that life on dialysis was so bad that she'd rather be dead. I sat down and talked to her for 30 minutes. It was mainly me talking and her crying. But she said to me, Finally, after I said to her, I know life on dialysis is bad, but you can get through it, and you're an excellent candidate for a kidney transplant. She finally said she agreed that she wanted to live. She said she no longer wanted to be DNR. I left her room, closed the door, ripped down the sign that said DNR, tore it to shreds, threw it away. Fast forward 1 year, and she received a kidney transplant. Fast forward 10 years, and now she's the 59-year-old grandmother of 3 beautiful grandchildren, loving her life. Your primary care doctor has to get to know the hospitalist and vice versa, and unfortunately this doesn't happen now. They have to feel free to call each other and talk to each other about you and what's going on with you. In my 20 years of working in this system, I've never seen a hospitalist pick up the phone and call your doctor, or your doctor call the hospitalist. The way the system works now is you're admitted to the hospital, your doctor sends you to the emergency room and talks to the emergency room doctor about you, who may see you for less than 5 minutes. The hospitalist then takes you as an admission, but he's completely left out of the information loop. The hospitalist has to be the one who's involved and who gets to know about you. Let's move to the middle of the hospital stay. You have to know how to get in touch with your hospitalist immediately in case you have a crisis or a problem. They have to give you a business card that has their name and phone number on it so that you can immediately get in touch with them. Plus, since they work shifts, they need to keep the patient's family, and the specialist constantly updated as to who that patient's doctor is. The hospitalist needs to communicate with the specialist on a daily basis and not just dictate a note into the computer. If a patient is admitted with a gastrointestinal bleed, I have to be told that they've suffered a heart attack during the night instead of me taking them down to the endoscopy suite to perform an endoscopy on them while they're having an acute heart attack, which could be dangerous to their health and could possibly even lead to their death. The way the system is now, the hospitalist doesn't communicate with me, and I'm left on my own to search the computer and find out what's going on with the patient. This is my father, Fred Weisberg, who's 91 years old and a World War II veteran. I'll talk about him more in a minute. But he's here for me to talk about the importance of you having an advocate with you when you're in the hospital. If you take nothing else from this talk, remember this. You should have someone else with you when you're hospitalized. You're sick. You're drugged because you have pain, and you give them pain medicine, and there's no doctor there who knows you. There's got to be someone, a parent, a child, a spouse, a friend, someone that you pay, who has your best interests at heart and is willing to stand up for you. That person can see who's coming and going, what they're saying, and what the plan for you is. My father suffered a broken hip and had to have hip replacement surgery. He was hospitalized and did well. I got the hospitalist number, her cell phone number, who was taking care of him. But then when he was transferred to the rehab unit, there was a problem with his Foley catheter. It wasn't working properly. I went to see him one night on a Saturday night, and he was constantly getting in and out of bed, and saying, Michael, 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 help me. And the nurses said he was confused. The Foley catheter was about 1/3 full. I said to the nurses, please call the hospitalist and have him evaluate my father's catheter. They called him, but he was tied up in the emergency room seeing patients, and he told them to give my father Haldol, a powerful sedative. Well, they gave my father Haldol, and he became more agitated and irritated and continued to want to get up on his new hip and walk to the bathroom. This went on for another hour, and I was getting more distressed. And I said to the nurses, please get in touch with the hospitalist. Again, he was too busy and couldn't see my dad, but he gave orders to go ahead and move my father to a room closer to the nursing station and to tie him down in 4-point restraints, tying his arms and legs down so he couldn't get out of the hospital and injure himself. I knew how dangerous 4-point restraints can be. Patients can aspirate, they can get stomach contents into their lungs and get pneumonia and die. So I immediately thought, let me call the hospitalist who originally admitted my father and see what she says. I called her and told her I thought the Foley catheter wasn't working properly, and she said she'd have the nurses replace it. Well, sure enough, the nurses went to take down the balloon. There's a balloon that has to be inflated with 10 cc's of water for a catheter to work. The nurse put the empty syringe into the catheter, pulled back to get out the 10 cc's of water, and all that came back was air. They never inflated the balloon, so the catheter wasn't working. They took out the catheter, put a new catheter in, and I watched as they slowly gave him 10 cc's of water and inflated the balloon so that the Foley catheter was working properly. My father immediately filled 2 bags of the Foley with urine and then fell back into the deepest sleep I've ever seen him fall into. If I hadn't been there that night as his advocate, he very well could have been strapped down, aspirated, and died. Let's move on to the discharge. The way it's set up now, the hospitalist dictates a note saying, patient to follow up with Dr. Weisberg in 1 week. Well, I may be in Giverny, France, admiring Monet's water lilies and not available to see the patient. The hospitalist needs to call the consulting doctors as well as the primary doctor and tell them about the patient's hospital stay as well as his expectations for follow-up. I think that there should be a hospitalist and a caseworker assigned to every patient for the first 2 weeks after discharge to make sure that the patient's medications are affordable, picked up, and taken, and that the patient's appointments for follow-up are made and kept. This is my son, Reed, who's a first-year medical student at Baylor College of Medicine, who I promised I'd put a slide in, so here it is, Reed. But he's here for a couple reasons. First of all, he's here because I have tremendous optimism in the future of medicine because of people like Reed, who are going into medicine for the right reason. They truly want to help people, and they truly feel that it's the most noble profession in the world. But I also have the slide here because I want to say that I think that if someone wants to be a hospitalist, they have to go through special training to do that. There are hospitalist training programs now. The first one was set up at the University of Colorado in Denver in 2004. But I think all hospitalists need to go through these training programs and learn 3 things. I think they need to learn how to take care of sick patients, of course, under the most dire circumstances. But I also think they need to know who, why, and when to consult. And finally, I think it's very important that the hospitalists learn how to talk to patients and the patient's family in short periods of time and when things are going wild. What would I do with the health insurance companies? If it was up to me, we would get rid of them completely, and we would return to a fee-for-service system. Many of my patients already have this. They have deductibles of $10,000 to $15,000, so that they pay completely out of pocket until they reach this level, and then the insurance company kicks in. So it's more like catastrophic insurance. I say get rid of the insurance companies completely and have a catastrophic insurance paid for either by a consortium of the insurance companies or by the government itself. However, if my dreams can't be realized, what would I change in order to operate in the current system? First, the insurance companies need to pay doctors more for taking care of sick patients and spending time in the hospital. Second, the insurance companies need to get the hell out of the way of doctors' practice of medicine. Insurance companies are practicing medicine now, and they don't have a license. How do they do this? Formularies. Formularies are lists of medicines that your insurance companies will pay for. Well, it might not be the right medicine for you. You may have done well on a medicine for 30 years, and all of a sudden, the insurance company won't pay for it, so you can't take it. And so the insurance company says, you take a different medicine, which you may have a bad outcome from, and may land you in the hospital. What medicines you take should be between you and the insurance company and nobody else. The insurance companies have peer-to-peer review, where the doctors have to call the insurance company and ask and beg for 30 minutes to get a CAT scan or MRI scan approved for you. I'm the one taking care of you, and I'm the one who knows that CAT scan needs to be done. It shouldn't be up to the insurance companies. Thank you. Finally, I think the insurance companies should pay doctors not only based on what happens to you in the hospital, but within the first 2 weeks after your discharge. Both the hospitals and doctors' pay should be tied to this, because we're under tremendous pressure now to get you out of the hospital as quickly as possible. You may be better, but not well. And people that are better go home and get sick again and come right back to the hospital. Hippocrates, the ancient father of medicine, said, wherever the art of medicine is loved, there is also a love of humanity. In order to regain the art of medicine, it all comes down to one word, and that word is responsibility. When we become doctors and recite the Hippocratic Oath, we accept the responsibility for healing sick patients. That responsibility has been lost. I challenge you, the public, to demand that doctors reclaim their right as healers and their primary role as healers, and that doctors inside and outside of the hospital make the changes necessary to keep America's healthcare system the greatest in the world. Thank you.